Hello and welcome to the St. Jude Crosson Cancer Institute's Preoperative Prostatectomy course. In this course, you will learn about what to expect before, during, and after surgery, as well as learn about the benefits of pelvic rehabilitation or pelvic rehab, and also utilize the helpful tips and strategies in preparing for surgery and pelvic rehab. You should have received a packet that contains pertinent information for this course. Prostate cancer is the most common cancer found in our male population. Unfortunately, as one ages, the risk for prostate cancer increases. Not all prostate cancers are the same. Some are slow growing while some are more aggressive and grow rapidly. You may know of a friend or family who has had prostate cancer and shared what treatment route they went with. There are 3 components that the doctor looks at when dealing with prostate cancer: PSA, Gleason score, and digital rectal exam. With the PSA, there may have been a rise in your PSA levels that prompted further workup to be done. For example, a prostate biopsy. Once a biopsy is done, the pathologist will review the tissue collected and examine it underneath a microscope. The Gleason score is the 2 most prominent cells seen. For example, a 3 plus 4 equaling a 7 or a 4 plus 4 equaling an 8. The score can be from 0 to 10. The digital rectal exam is when the doctor checks for any prostate abnormalities, such as was there a firmness noted on the prostate or was a nodule felt. These findings places a patient into 3 different risk categories: low, intermediate, or high. Depending on what your risk category is, determines what treatment options you have available. In this case, you are proceeding with a robotic prostatectomy. In this slide, you will see the image of the prostate, bladder, and rectum. The prostate is located just below the bladder and is attached. There is a tubing where the urine comes out from called the urethra that goes through the prostate and penis. When the prostate is removed, the surgeon is unable to detach the tubing and the prostate, therefore removing part of the tubing. The remaining tubing will get reattached to the bladder. To the right of the prostate is the rectum. There are definitely a lot of benefits to having a robotic prostatectomy done. The surgery is minimally invasive, involving a few small incisions that the surgeon will make. Please refer to the picture with the red dots. The incisions are about 1 inch to 1.5 inches long. It is not uncommon to see bruising or small amounts of drainage to the area. There is significantly less pain and blood with this procedure, fewer complications, and less scarring involved. The duration of the procedure is about 2 to 2.5 hours long. Anticipate staying at the hospital for 1 to 2 nights. There is a quicker recovery and return to daily activities with this procedure. The doctor will also try and spare the nerves for sexual potency. The equipment used for this procedure is the Da Vinci robot. It allows the surgeon to move the robotic arms for more precise incisions. In this picture, your surgeon will be at the console that you see to the left. The assisting physician watches the monitors, gives feedback to the treating surgeon, and changes any tools needed on the ends of the arms of the robot. There are different pieces that attach to the end of the arms that help the surgeon at different points of the surgery. There will be other staff involved, such as the OR nurse, anesthesiologist present in the OR room. There are 2 items that will be placed while you are under anesthesia: the JP drain and Foley catheter. The JP drain will be placed during your surgery. The drain will help eliminate any excess fluids in your body to help minimize any issues with infection. It is important to measure the amount of drainage. The bulb is where the fluid contents will accumulate. It works by suction. As the fluid builds up, the bulb will expand. The stopper will open the bulb to empty the contents. The port is where the contents will empty out from. The drainage end is where the fluids will enter and go into the bulb. The plastic hang ring is used with a safety pin and is attached to the gown to keep the drain from dangling around. Anticipate having the drain removed before you get discharged from the hospital. There has been instances where patients may go home with the drain. If you do, a drain log will be given to you in your packet to help keep track. The drain may be removed when the amount of drainage drops below a specific level. The Foley catheter will collect the urine from your bladder. The catheter will allow the bladder and urethra to heal. Make sure the bag is always hung below the level of your bladder for proper emptying. It is not uncommon if you feel the need or sensation to urinate. This is from the catheter being in your bladder. Do not be alarmed if there are blood clots. The urine appears blood-tinged, pink, or tea color in the catheter tubing or bag. This is from the surgery and the catheter rubbing on the inside of the bladder. Never pull on the catheter. It is not uncommon to have bladder spasms while the catheter is in. Leaking around the catheter is usually from a spasm. You will go home with the catheter and will be in for about 7 to 14 days. Your surgeon will determine when it is time to remove it. The end of the tubing is inserted in the urethra that goes through the penis. Part of that tubing that is inserted inflates into a balloon to keep the catheter in place. The tubing with the drainage end leads into the rest of the tubing where the urine will empty into. The catheter bag has measurements on the bag for the staff to measure how much urine there is. The valve is where the urine will empty out from. The clamp will keep the urine from leaking out of the bag. When it is unclamped, the urine will come out. The handles will release the valve where the urine will exit once it is unclamped. In this image, you will see what a traditional or open prostatectomy looks like. There is a longer incision down the center of the abdomen versus the incisions from the robotic prostatectomy. It is about 4 to 5 inches long, and staples are used to close up the incision. The duration of this procedure is about 4 to 4.5 hours long, with a longer stay at the hospital. The recovery period from this procedure is a little bit longer than the robotic prostatectomy. It can be up to 6 weeks or more. With this procedure, the doctor will still try and spare the nerves for sexual potency. When you are preparing for surgery, instructions will be given by your surgeon. Usually, patients are on a clear liquid diet 1 to 2 days prior. This is done to clean out the bowels in preparation for surgery. There may be a bowel prep included that you will need to do the day before, and depending on who your surgeon is. They will also let you know not to eat or drink anything after midnight. Pre-surgical tests are pretty simple and short and done at our outpatient testing center. This usually involves blood work, urine test, EKG, and chest x-ray. If you have any cardiac issues, you may need to get cleared by your cardiologist. A helpful reminder is that you will receive phone calls in the days leading up to your surgery. This is to ensure that everything is ready for you prior to your arrival. Please know that they may ask the same questions, but this is for your safety. On the day of your surgery, make sure you arrive on time. Allow extra time to find where you need to park and check in. Bring a list of medications with you to the hospital. Once you have arrived, you will check in with registration. They may have forms that need to be filled out or signed. Once paperwork has been completed, you will be taken to the preoperative or pre-op unit where the staff will ask you questions, get you set up for surgery, change into a gown, take vital signs, and start an IV. Your anesthesiologist and surgeon usually will pop in before surgery will take place, and then you'll be taken to the OR and have surgery. The operating room is located in the 3rd floor of the northwest tower, the tower closest to the cafeteria. While you are undergoing surgery, your family or caregiver will be waiting in the 3rd floor waiting area. When the surgery is complete, the surgeon will provide an update on how the surgery went. You will then be taken to the recovery department for about an hour or so to ensure that things are stable and you have recovered from the surgery prior to getting transferred to your room on the 5th floor of the Northwest Tower. The room is private and there is an area for your family or caregiver to stay the night. The items that you see listed here are your expectations during your stay at the hospital. Your physician may use a number of options to help manage your pain. You may have a patient-controlled analgesia pump or PCA that allows you to give yourself a small dose of pain medication every so often. There is a locking mechanism so it is safe and there's no issues in receiving too much pain medication. The nurses may also be giving you pain medications either in your IV or as pills to help manage your pain. Please take the pain pills when you start to experience pain instead of waiting when the pain is severe. You will have better pain maintenance and control if you are being proactive in managing your pain early. Pain medications can often be constipating. Do not use suppositories, enemas, or rectal thermometers. It is not uncommon to have blood in your urine after a bowel movement. Straining during a bowel movement may cause some urine leakage from around the catheter. The catheter is inserted while you are asleep in the OR. The urinary catheter will collect the urine from your bladder. The catheter will allow the bladder and urethra to heal. The urine output will be managed by the staff. You may notice when you wake up that your urine is not its normal color. Often it is red, pink, or tea-colored. This is because there is blood in it. This is normal and may continue when you are at home. The color should start to subside. The JP drain is placed in your abdomen to help remove excess fluid that collects at the site of surgery. This drain will help minimize any issues or problems with infection. It is important to measure the amount of drainage after surgery. While you are in the hospital, the staff will be monitoring and managing the drain. If you end up going home with a JP drain, you will need to learn how to empty it. A drain log will be given in your packet to help keep track. The drain may be removed when the amount of drainage drops below a specific level. Majority of the time, the drain should be removed before you get discharged from the hospital. For the first 24 hours, you will likely be able to have ice chips. This is because we need your colon to start working again. Anesthesia and manipulation during the surgery causes your intestines to fall asleep. It takes some time for them to regain their function. Therefore, until that happens, you won't be able to eat much. You may feel even worse if you try to eat solid foods right away. Your nurses will be asking you if you are passing any gas, and they will listen to your belly. This is how they assess whether or not your intestines are working again. Once you are able to tolerate ice chips, your diet can be advanced as tolerated. Do not be surprised if your nurses get you up and walking a day or so of your surgery. This is important to prevent any complications like blood clots and to get you to take deep breaths. This is helpful in minimizing constipation as well as waking your gut up from surgery. And just to reinforce, anticipate staying at the hospital 1 to 2 nights after surgery. Home care has similar concepts of expectations from your stay at the hospital. Your surgeon will most likely give you a prescription for oral pain medications. This is usually a narcotic which comes into play when we talk about constipation. The important thing about pain management is to take a pain pill before it gets worse. It is harder to get control of it when the pain is not managed earlier. Do not drive while you are taking pain medications as it may cause drowsiness. The catheter works by gravity, so when you're at home, it is important to remember for any significant length of time, it needs to be below your hip to drain properly. Use the hook to hang it on bedside tables, frames of mattresses, or off of chairs. Some people put it on the ground when they sleep if their bed is low enough. It is also okay to place it on the bed with the patient. When it comes to clothing, I recommend using a pair of warm-ups or sweatpants with the elastic at the bottom to go home from the hospital. This way, the bag can be hidden in your pant leg. Otherwise, cargo shorts are good for their low-hanging pockets to hook the bag onto. Your urine may continue to have some blood or small blood clots in it. That is normal, but should go away over time. You or your caregiver will need to manage and empty the catheter at home. Please wash your hands prior to emptying the catheter. Bring the catheter to the toilet. Squeeze both handles to release the valve. Aim the valve towards the toilet and unclamp the clamp and allow the urine to empty from the bag. Once the urine has been emptied, be sure to clamp it afterwards and put the handles back into place. You can give it a little tug to make sure it is secure. Then wash your hands after emptying the catheter. Sometimes you can have bladder spasms that can cause some urine to leak out of the penis. You may also experience penile, scrotal swelling, or bruising. This is not uncommon and will also resolve over time. You can elevate your scrotum with a towel or washcloth when you're sitting or lying down to help with any discomfort and help decrease the swelling. If you see blood in your urine, cut back on your activity and increase your fluid intake. If it does not clear up, call your urologist. If the penis becomes irritated because of the catheter, you may apply an antibiotic ointment such as Neosporin to the area after gently washing. The drain usually comes out before you leave the hospital. If you need to go home with the drain, you will need to learn how to empty it. Before you empty the drain, please wash your hands. Bring the drain to the toilet or sink and lift up the stopper and pour out the contents from the port. Once the contents are emptied, squeeze the bulb of the drain because the drain works by suction, and then close it with a stopper. Then wash your hands after emptying the drain. You will need to keep track of how much comes out of the drain and record the measurements in the drain log. The doctor will take it out at your visit in his office. Eating foods high in protein and vitamin C promote wound healing. A well-balanced diet promotes good health and aids in your recovery. Avoid a diet high in fat, salt, and fast foods. You might notice that you may not have much of an appetite. This is not uncommon after surgery. Drink at least 8 to 10 glasses of fluids every day while you have the catheter in and after it is removed. If you notice blood in your urine, increase your fluid intake. The pain medication can cause constipation, so it is important to drink plenty of fluids, eat a healthy diet with fruits and vegetables, and walking around is tolerated. Eating a well-balanced diet, including foods high in fiber, fruits, vegetables, and whole grains, will help avoid problems such as constipation and bloating. Drinking 8 to 10 glasses of fluids helps prevent constipation. The surgery performed took place right next to the rectum, so it is important to not strain when you have a bowel movement. Your surgeon will usually prescribe medications for constipation. If not, be sure to have some stool softener or laxative medications available. Do not use suppositories, enemas, or rectal thermometers. It is not uncommon to have some blood in your urine after a bowel movement. Straining during bowel movements may cause some urine leakage from around the catheter. You will notice that you will regain more energy each day after surgery. Feel free to increase your activity, such as walking and climbing the stairs as tolerated. It is important that you do not drive or lift anything over 5 pounds until you are cleared by your surgeon to do so. Do not participate in biking, motorcycling, horseback riding, or any similar activities. Also, take it slow with exercising and talk to your doctor when it is safe for you to return to your exercise regimen. I would also like to note that erectile function can be affected after surgery. Recovery of erections after surgery can be slow and time-dependent. Even though the nerves are spared, there can be some injury from the trauma or stretching from the procedure. These nerves will need some time to heal. These are the following problems you need to notify your surgeon about. Any signs of fever greater than 100, sweats or chills, pain that is not relieved by the pain medications you were prescribed, heavy bleeding or clots in your urine, Any issues with a decrease in urine output or no urine output may indicate that a Foley catheter needs to be put back in. Redness, separation, signs of infection such as foul smelling or pus through the incision sites. Swelling and pain to the legs, shortness of breath, or chest pain. So please be sure to notify your doctor or contact the on-call physician in their office. Otherwise, for any immediate issues, please go to the emergency room. If you're still having any questions at this point before, during, or after your surgery, we have a wonderful resource called the Shared Journey Program. It is a unique program created for our prostate patients and spouses. This program is a free resource and is of no cost to you. It has been around since 2011. These volunteers have gone through the same cancer journey as you have. This type of resource was not available during their journey, and so this program was created. They serve as a source of support and mentorship for our patients and spouses. Our volunteers go through annual hospital training to continue to be a volunteer. There are also spouses that are volunteers who offer support to the wives. When I provide information to you, it is coming from a clinical standpoint versus someone who has gone through it firsthand. This is a wonderful program that would be a benefit to you and your spouse. If you are interested, there is a shared journey form that needs to be filled out and is included in your packet. It is 2 pages and is asking general information such as your name, address, prostate cancer information, and how you'd like to be contacted, whether it's by phone call, text, email, or face-to-face. Once the form is completed, be sure to return it back to the Navigator via text, email, or mail. I would like to share what you will be receiving at some point down the line. The Survivorship Care Plan is a treatment summary for your prostate cancer. You will receive it sometime within 6 months to a year after your treatment is completed. It entails additional information such as persistent symptoms and side effects from your treatment, such as urinary dysfunction, survivor issues that may impact your quality of life, such as physical function, sexual dysfunction, relationship changes, or fatigue, health promotion wellness, which encourages you to make positive lifestyle changes such as activity, diet, and avoiding tobacco or alcohol. Support services that is available for you, such as support groups or referrals for physical therapy. Survivorship care resources, which provide you with helpful websites in moving forward after your cancer treatment. And lastly, a follow-up care plan for your cancer by doing your routine PSAs with your urologist, your primary care physician, as well as screening for other cancers such as colon, lung, and skin. This is what a sample care plan would look like. You can see the additional information I described, such as persistent symptoms and side effects, survivor issues, health promotion wellness, support services, survivorship care resources, and lastly, follow-up care plan. What you need to know about the Survivorship Care Plan at this time is that it will be mailed out to you or given at your office visit. Someone will contact you to follow up and see if you've received the information, check if the information is correct and up to date, and answer any questions you may have about the care plan. This care plan will be helpful to have for your medical records. I will now go over the pelvic rehabilitation portion. Urinary incontinence is common after prostatectomy, but with proper awareness and exercise regimen, you can improve your quality of life and decrease leakage. In order to get started with pelvic rehab, the physical therapist will need a referral put in by your doctor that performed the surgery. They will focus and work on post-surgical weakness of your pelvic floor muscles and help with the stress urinary incontinence that can occur after surgery. There are various tools and strategies that they will use to help you recover after surgery. For example, biofeedback, behavior modification such as exercise, fluid intake, and body mechanics. These items will be further discussed in detail in this course. Stress urinary incontinence, or SUI, may occur once the Foley catheter is removed. It may last for several weeks to months. Regaining urinary control can occur within 6 months to a year for some patients. Each patient is different. Recovery is in stages, meaning that once surgery is performed, not all the issues and problems go back to normal right away. It is a process and will take some time. The sensation of bladder filling may be delayed once the Foley catheter is removed. There are less incontinence issues when one is laying down or resting versus during the day when there is more strain on the bladder due to gravity and the pelvic floor muscles are fatigued. There are various factors that may speed up the recovery process after surgery. Your age, health status. For example, do you have a lot of medical issues? Those that may have more medical conditions may potentially recover a little slowly versus someone who does not have any or little issues. Your fitness level. How active are you? Your adherence and compliance level in doing the assigned exercise regimen that the pelvic floor therapist would like you to do. Bladder training, diet, and constipation prevention are other additional components that may speed up the recovery process. How can you manage stress incontinence? You'll want to limit the amount of caffeinated, carbonated, or alcoholic beverages that you consume. These are considered irritants. If you absolutely cannot go without these beverages, a helpful tip to keep in mind is that if you drink any of these beverages, to follow it up by drinking water to balance it out. Drinking fluids will be very helpful. Some patients may think that if they do not drink as much fluids, they will not have to worry about urinating as often. What ends up happening if one drinks little to no fluids is that the urine will get darker and concentrated, which indicates dehydration, causing the bladder to get irritated and have the patient prone to developing a urinary infection. So please make sure to stay well hydrated. The pelvic rehab therapist will teach you how to do the Kegel exercises once the catheter has been removed. These exercises will help you regain your continence and should be done on a regular basis. Some helpful tips to keep in mind is to avoid constipation and straining of any kind, and never holding your breath while doing some kind of activity or exerting yourself. Most men have difficulty with urinary control after surgery and require some form of protection. Some brands include Depends, Tina, Prevail, or Attends. Local drugstores carry a starter kit for incontinence. You may also find incontinence products such as the pads and disposable underwear online. There are several different kinds of pads to assist you while you heal from your surgery and once the Foley catheter comes out. It is recommended that you purchase some supplies before you have your appointment to remove the Foley catheter. Layering pads allow for easier changing when you are out and about. For example, using disposable underwear and layering it with a pad for extra coverage and protection versus wearing your underwear and layering it with a pad with less backup protection and constant changing of your underwear. You can notice your recovery progress by the reduction in thickness or number of pads used daily. For example, using 3 pads and now using 1 pad, or initially using thicker pads and switching over to thinner pads. There is a helpful quote to keep in mind: pad up and play on, meaning that just because you are dealing with the incontinence, it shouldn't stop you from doing your daily activities. No one except your caregiver or loved ones would know that you are dealing with the incontinence. This image gives you an idea where the bladder, rectum, pelvic floor muscle, and prostate once was. Without a prostate to support your urethra and bladder, your pelvic floor muscles have to compensate. The pelvic floor muscles consist of multiple layers that support the bladder by forming a sling from the pubic bone to the tailbone, or coccyx. They need to get strong enough so they can make up for some of the lost support that occurs after surgery. Just like a bodybuilder is going to do exercises for the whole body for a good tone, is what you are doing for your pelvic floor muscles. In the picture, you see where the pelvic floor muscle is located. This is what the therapist will be working on to strengthen that muscle. When I was discussing earlier about the importance of constipation prevention and managing it properly, you can visually picture on the image if someone was constipated and how it could be pressing on the bladder and causing leakage. Pelvic floor muscle training usually gets started once the Foley catheter has been removed and you've had some time for your body to recuperate from the surgery. The physical therapist will help you find those muscle cues. For example, being able to stop the flow of urine midstream uses those pelvic floor muscles. If you feel a tightening at the base of the penis, lifting the anus and testicles up is another cue. And if you're able to squeeze your anus and prevent the gas from passing is also utilizing that muscle. Feel free to practice this before your surgery to give you some idea of what those muscles feel like. Please do not do these exercises while the Foley catheter is in. Please avoid tightening your buttocks, thighs, or abdomen. If you remember the previous slide, you will see that the buttocks, thighs, and abdomen are nowhere near the pelvic floor muscles. Pelvic floor muscle training consists of doing muscle contractions that are held for a period of time followed by several seconds of resting. For example, one repetition would be holding for 5 seconds and resting for 10. So a sample would be to do 10 repetitions 3 times a day. Each time you are doing these exercises, you are gaining that strength and endurance back. Your pelvic floor muscle training will also include testing you on how you do these exercises when you are laying down, sitting, and standing. The precision of the contraction is more important than the force of contraction. As these exercises are done more frequently, you are gaining that endurance back. They will also work with you on performing gentle breathing when exercising. Pelvic bracing is a term used when one is preventing leakage due to some sort of strain or effort. You are being proactive in preventing leakage by tightening your pelvic floor muscle just before doing some activity, such as bending, lifting, or standing up. Another helpful quote to keep in mind is to squeeze before you sneeze or blow before you go. Biofeedback is another helpful technique that the pelvic floor therapist will use. It is a painless tool. If you look at the picture, you will see sensors similar to an EKG where the pads are placed. The pads are applied to the perineal area. On the monitor, you will see how someone is doing with their Kegel exercises. Please refer to the top image on the monitor. The tall peaks shows how someone is holding their Kegel muscle, while the lower and steady drop on the graph shows when the muscle is relaxed and at rest. This allows the patient to visually see how they are doing with their Kegel exercises. Just to recap, your doctor will need to put a referral in for you to start pelvic rehabilitation. Once you get started with rehab, the therapist will help you to train and regain that continence back. Using helpful tools such as biofeedback technique can train people to locate and activate their pelvic floor muscle. By taking this course and being informed on what to expect before, during, and after surgery helps our patients to prepare for a successful and speedy recovery. Please see some important numbers and resources here, such as urologist, nurse navigator, physical therapist, and shared journey program to call and get connected with. Thank you for attending this course.